So I'm Roger Lyons. I'm a hematologist with Texas Oncology and the U.S. Oncology Network. And I have several jobs for both Texas Oncology and U.S. Oncology, largely related to hematology and the laboratory services. Well, this is a long-term interest for me, and we actually were involved in the original studies with azacitidine many years ago in the dosing schedules. But we realized that we have this enormous reservoir of records that are available to us. So that our record system has been in place for over 10 years. The IPSS-R score has been in use for at least 10 years. And we had all this data available that we could search and look at to see if the data was similar to what the published data was. So as you may be aware, when the prognostic scoring systems were developed for myelodysplasia, they were developed almost entirely in academic medical centers, where the patient population tends to be a little different. The patterns of treatment often are different. The outcomes may or may not be different. We didn't know, but we had this resource to look at and to be able to pull all this data together and say whether or not the scoring systems still were valid and whether or not we thought there were changes in that could be useful. Well, I think the most important findings are that the IPSS score remains valid. And over the years, it appears to maintain its prognostic importance in determining whether or not patients not necessarily will respond, but how long they will survive. The data appear to be very similar to what the original IPSS score data was, which is interesting, encouraging that the scoring system works, but discouraging that the data did not show, at least, and it's not a head-to-head study, of course, did not show that there was a significant improvement in survival. So basically, that's what the study showed. Very good similarity for the scoring system. Doesn't mean that some of the newer things won't be useful, but very important to know that what we see in the community is similar to what was looked at initially for the scoring system. Well, this is a very difficult situation, of course, has been on the mind of many, many people over the years as hypomethylating agents really changed the picture for MDS. There really was nothing before that was useful. In many attempts since they were introduced, have not done well. They failed. We do have some targeted agents when you have specific mutations where you can introduce a drug that works well for 5q- disease, for example. But overall, it's been very disappointing. And so I think the objective, I think, is to encourage people to continue along this way. As you know, there are other studies presented, some that I was involved in, co-author on, looking at other agents, and they're not all encouraging. Many of these have initial exciting responses and results. The long-term results have not always helped. So I think we need to continue to look at various options. Of course, the best thing that you can do for these patients is to have a bone marrow transplant, but this is a disease of the elderly, and most patients are just not eligible for allogeneic bone marrow transplant. Well, there are many approaches, and I think that if you look through the abstracts, you'll see many different approaches. Many of them are based on immune modulation, which is sort of I can't describe it exactly, but what's hot right now is immune modulation. If you can modify the immune system so that you can bring it into a mechanism to attack the malignant cells. That's an approach that's being used basically in all cancers right now. And there are multiple attempts to do that in myelodysplasia. And some appear early promising, but so far I don't think anything is game-changing here. So I think we need to keep working on that area, to see if we can find something that really changes the way things, the way cells grow, and to bring the patient's own immune systems into action against their malignancy. We do have the problem, of course, in this older group of patients that they don't have much reserve. And so you can't really work, you got to be very careful not to overdo it. And so that you can really cause more problems than benefit if you approach it in the wrong way. So I think that there are exciting new things out there, but nothing that has struck my eye that's going to change the field right now, other than the specific genomic markers where drugs are being developed to target the mutation, and those are appearing intermittently as time goes on, and I think that seems to be the thing that's going to change things more quickly, but it's not a broad approach to this disease, where most patients won't have a target that has a drug available, that's druggable, that's treatable.